Thank you, Kelly, and I hope the weather is beautiful in Kansas. It's absolutely gorgeous here in Richmond today and right in the upper 60s, and thanks for inviting me to talk today. So we're going to talk about symptom management and symptoms related to not just the disease itself, but also mainly to the side effects of the therapies. I've seen some of those questions in the chat box already about neuropathy and things like that. This is a slide deck or part of a slide deck that's put out by the Nurse Leadership Board of the International Myeloma Foundation. And the main goal of the Nurse Leadership Board is really to patient education and nursing education, to educate those nurses who take care of patients who treat multiple myeloma. And again, we really focus on symptom management as much as anything. And so this is the title of it, Be the Commander of Your Galactic Journey, and this is the constellation of symptoms as well. So when we think about symptoms that are, I guess, experienced by patients with multiple myeloma, they can be caused by two things. Of course, if we look on the left, we can see the myeloma itself can cause symptoms. Calcium elevation can cause fatigue. We see infection. We see anemia associated with that. And we also see symptoms related to the treatment. And that's over on the right. So we see the myelosuppression where we can get infections, we can get fatigue and things like that as well. And you can see they're not mutually exclusive. And when patients are diagnosed, typically what they're experiencing are symptoms related to the myeloma. But as we get that myeloma under control with the treatments, the various treatments that we use, then, of course, then we have the side effects related to the treatments. And so when we think about treatment of myeloma, we're not thinking about just the treatment that kills the myeloma cells, but we're also talking about some supportive care as well. And that is treatment to alleviate some of these other symptoms that you see associated here on the left, or on the right, excuse me. All right, so these next three slides, and this kind of been, I guess, expressed before, but these next three slides are really looking at the approved drugs for multiple myeloma. And there are actually what I would call 14 newer agents, and they're actually in 8 different categories. So we have quite a few new ones. There's a couple of older ones which are listed in here as well, which are classic chemotherapy agents. But what we have here are the drugs listed across the top, and you can see on the red, we talk about the immunomodulatory agents, and on the right there is the proteasome inhibitors as well. Going down the left-hand side, we see neuropathy, thrombosis. These are all the potential side effects associated with these different agents. And so when we think about treating patients up front, we don't always also just think about, well, what's the best agents to use? We sometimes have to think about what are some of the side effects associated with that. So let's, for example, if a patient comes in with significant diabetic neuropathy, it might be difficult to use one of our proteasome inhibitors. One of our most common upfront regimens is Velcade, Revlimid, dexamethasone. But Velcade carries a pretty significant risk of neuropathy. And so the actual problems a person may be having already may be basically dictating what medications that we can use. So that might be difficult. Again, the immunomodulatory agents, thalidomide, Revlimid, and Pomalyst, which I think everybody's probably familiar with, those are all oral agents. The proteasome inhibitors, bortezomib, carfilzomib, ixazomib. We actually have sub-Q, IV, and oral versions there. Going to the next slide, again, Dr. Abdallah just talked about the monoclonal antibodies, the daratumumab, elotuzumab, and isatuximab. They basically harness your immune system to recognize the myeloma cells, and that's how they kill them. The nice thing about these particular agents is they don't have significant side effects, so they're pretty good from that standpoint. And so those are the naked antibodies. The other antibody which he talked about was the Blenrep, or the belantamab, which is a monoclonal antibody drug conjugate, and that is also an antibody which recognizes the myeloma cell, but as Dr. Abdallah pointed out, that carries a payload directly to the myeloma cell, and so it doesn't really harness your immune system to kill the cell, but carries a chemotherapy agent directly to it. In red here, we have the HDAC inhibitors and the signs. Feridac and Exposio, better known for us as selinexor, is this last one most recently approved. These are probably the agents which cause us the most difficulty in terms of GI side effects with the nausea, vomiting, and diarrhea. Most of our other agents are really pretty good from that standpoint. And then on the last slide here, when we look at the list of myeloma drugs, we have some of the classic chemotherapy agents, the anthracycline there on the left, which is also known as Doxil. We have the alkylating agents, Cytoxan, and melphalan. Melphalan, I would point out, is the drug which you get when you get a stem cell transplant. So that's the drug which we use to basically ablate the bone marrow and try to kill all remaining myeloma cells in there. And so those are classic alkylating agents. We now have the alkylator conjugate, the melphalan flufenamide or the Pepaxto, and I kind of describe that to patients as kind of melphalan with a slab of bacon added. And so the bacon makes everything better. And so what this conjugate does is it actually targets the melphalan more directly to the myeloma cell, so we get more directed killing, unlike just straight melphalan itself. And then the CAR T is listed on here as well, and that was just approved in the last 2 weeks. And so that's something very new and real as well. So when we think about all these drugs, again, we got lots of combinations, and I think that was pointed out. So when we have so many combinations, if we look at, NCCN guidelines, NCCN recognizes 46 different regimens that you can use to treat patients with multiple myeloma. So lots of options, and again, sometimes it can be a challenge to decide which option to use. But what I would point out is all of these agents come with specific side effects, and it's important to know those side effects, especially as we start going with triplets and quads, that we're actually adding more side effects potentially with each additional combination. And I think if we start out and we think about the side effects, probably the one which impacts patients the most, and we find in pretty much every single regimen, is the steroids, the dexamethasone, prednisone, whichever it might be. That's more or less public enemy number one. And why do we use steroids? Well, steroids work. They've been used since the 1960s. They're very good at killing myeloma cells. Unfortunately, you have to use them in very, very high doses to achieve that cell kill. And so there's a lot of side effects, and I probably don't have to go over a whole lot of them. They're listed on the left. Probably the biggest ones, the irritability and mood swings, then difficulty sleeping. That's the most common complaints we get. But of course, people can get heartburn with these, weight gain, for those people who have diabetes issues, elevation in blood sugar. So for us, when we think about all these, how do we manage those steroid side effects? And that can be quite the challenge. One of the things that we talk about is having a consistent schedule, taking them in the morning or in the evening. Very often we have our patients take these drugs in the evening prior to going to sleep. By the time they really exert their effects on the central nervous system of the brain, it's time to get up in the morning. If you usually take these steroids early in the morning, you're going to have a very difficult time sleeping that night. We often tell patients, pick a day of the week that you want to be taking these, and let's work with that. Some patients, obviously, if they're working 5 days a week, they may not want to do this on a Wednesday, but might do it on a Friday, so that Saturday can be a little more less of a challenge for them with their work schedule. Certainly take these with food. If you have acid buildup, which is something that's going to happen with all steroids, we have over-the-counters like Zantac and things like that. We have prescription medications as well. And then often we have to actually prescribe other medications as well, because these do suppress the immune system a little bit. Sometimes patients are going to be susceptible to shingles or thrush or some other infections. And very often other medications we may have to actually prescribe would be sometimes anti-anxiety medications to help patients get to sleep at night. Other times we bring in the primary care provider to help us with patients who have diabetes, and patients who may not be on insulin may have to be on insulin during the times that they take their steroids as well. So a lot of problems associated with that. The only good news I have is that basically once your myeloma gets under control, we can decrease the dose of the steroids, and rarely do we ever use any type of high dose steroid in the maintenance setting then as well. So a lot of problems associated with that. And again, I think from patient standpoint, that's public enemy number one. Listed on this side is kind of a constellation of symptoms. We put these together: fatigue, depression, anxiety, because they can very often occur together. They all affect quality of life, your relationships, and a lot of different sources. Some of those sources can, again, just be due to the steroids, or we get, again, those irritability, insomnia, and just, again, not taking care of all the other side effects can lead to these problems. So how do we manage this? Well, certainly we can manage it with some medications. For patients who are depressed, we can manage that then as well. But there are other things that are non-pharmacologic that are listed here. Certainly exercising within your capability. That's what we would like patients to do. The classic line, if you don't use it, you lose it. That's absolutely true. So we encourage people to be as active as possible. Certainly support groups, whether they're social, whether they're like a support group you're involved in today, or whether there's something from your church or synagogue, then we, again, those are very important then as well. And of course, some people, do fine with some over-the-counter supplements and things like that as well. We have a very nice supportive care clinic, which manages both psychological issues, pain issues, and GI issues and things like that. So if you have the option of a supportive care clinic, certainly I would see if we can get a referral to them as well. If you think about the problems that we as providers think about that are more public enemy number one, this really kicks right up there. One would be infection prevention and treatment if you do have a problem. Patients with multiple myeloma do have compromised immune function. Initially, that's due to the multiple myeloma because that does compromise the immune system. And then secondly, as patients get treated then, we find that the immune system is compromised by the treatment which we're given patients. And so we always talk about good personal hygiene, keeping the hands clean, things like that, environmental control, always washing your hands, avoiding crowds. That's not so hard to do these days. We always had patients wear masks in the past. Everybody's doing that now. But other environmental controls, which I tell patients, is to think about when you're at home, those types of things that you use commonly, like the remote or a keyboard or an iPad or the refrigerator handle, those types of things that could spread germs as well. To clean those off on a very regular basis also. Certainly get the immunizations that you're due for. That's very important to prevent infections if you can. And then lastly, of course, sometimes we'll add medications in there as well for patients who are at high risk for infections. I am sure all of you have heard this from your oncology nurses, that if you have a fever of 100.4, that is something to be alarmed about. And if that continues, that's something that needs to be reported and taken care of right away. The other big one, which we think about as primary care, as providers, would be the possibility of a blood clots, or listed up here, deep vein thrombosis and pulmonary embolism. Number one for us is actually preventing these from happening. And number two is, if they do happen, you need to recognize the symptoms. So it's really important that we educate about what those symptoms might be. Because a DVT, which is a blood clot in a large vessel, which would be typically in the legs, or a pulmonary embolism, which is a blood clot in the lungs, we have those symptoms. Those are medical emergencies that need to be taken care of immediately. There are certain risk factors that can lend you to having one of these types of blood clots: personal or family history, lifestyle issues, so obesity or inactivity, smoking can be a problem, medications. Patients who are on birth control have a higher risk of blood clots as well. So what are the symptoms? If we look at the symptoms listed on there, so we think about a DVT or a blood clot in your leg: swelling, tightness, ache and pain, change in color. And it's usually going to happen on one leg as opposed to bilaterally. So if you see this happening in one leg, that's a red flag and something needs to be brought to the attention immediately to a provider. From a pulmonary embolus standpoint, chest or shoulder pain, shortness of breath, anxiety, rapid heart rate, those are things that usually occur in a constellation as well. So again, for us, preventing it, if it does happen, recognizing those symptoms is really important. So how do we prevent it as providers? Well, as providers, we know there are certain medications that lend themselves to thrombotic events, and so if we go back to those three slides, which talked about side effects, we know the immunomodulatory agents increase risk of blood clots. Carfilzomib does, dexamethasone it does, and so when we think about that, we think about those different types of chemotherapy regimens and the risks there. And so how might we change those if we need to? For most every patient who is treated for multiple myeloma, they are on some sort of medication to reduce their risk of a blood clot. For most patients without any risks, aspirin is perfectly fine. For patients who have higher risk, Coumadin can be used, but we very often use the direct oral anticoagulant agents these days because they're much easier to use then as well. In terms of self-management, again, stop smoking, weight management is a big thing, more activity and exercise as just shown right below there. For patients who are traveling, if you're traveling any distance in a car, get out on a regular basis and move. If you're in a plane, if you can get up and walk, I think that's more of a challenge these days because they want people to sit in their seats with their masks on, but certainly do those exercises while sitting in your seat to help prevent the blood clots and blood pooling in your legs, which can increase that risk. So GI symptoms, this is probably the one good part here, is that most of our medications that we use, with the exception of, again, the selinexor or the HDAC inhibitor, do not cause a lot of problems with nausea and vomiting. We do see problems with diarrhea and constipation pretty much with all of the medications. If we look over on the left, the diarrhea isn't always caused by just our medications that we give you, but sometimes look at your other medications as well. There's a list of things which can cause the diarrhea. Certain laxatives, antacids, some things over the counter can cause problems as well, certain things you eat. And so be wary of those things as well. Sometimes we don't always blame these specifically on the treatment. And how do we manage that? Well, certainly there are over-the-counter antidiarrheal medications. We do have some prescription ones if needed, Lamodal, Clotting, which is a cholesterol binding agent, which we'll use in patients who have really refractory diarrhea we can't get under control. And then fiber binding agents are great as well. When the fiber is in there, it actually binds on to the fluid and helps bulk up the stool. Increase your fluid intake if you're having diarrhea as well, because we don't want you to get dehydrated. Constipation, again, it could be a problem with our agents, but also it can be related to some of the other medications which taken over the counter, especially when patients are taking calcium or iron or vitamin D. So once again, increase your fiber. That's always a big thing. Those fiber binding agents, which you used for diarrhea, are great for constipation as well. Again, they hold on to water. That can help bulk up the stool and make that easier. And there are a lot of over-the-counter medications as well, which can help Docusate or Miralax or those types of things. Again, for nausea, we don't generally see a lot of problems with nausea associated with these medications, but we can certainly manage those as well. I think if patients have nausea, then we're really not doing our jobs. We've been managing all these diarrhea, constipation, and nausea for many, many years with patients with all forms of oncology problems. So we have plenty of great antiemetics. I often tell patients in terms of meals, big meals are a little bit overrated. If you can graze like a cow all day and kind of keep food in your stomach, that will often help as well. So we definitely have good ways of taking care of all these potential GI symptoms. And what about kidney function? Well, we always talk about kidney function with patients with multiple myeloma, and in the box listed down there, it says many patients will experience kidney function problems at some point. Probably about 20% of patients are diagnosed. They have some type of a kidney dysfunction. Some patients go immediately to dialysis. What are the risk factors for kidney dysfunction? Well, it's the active myeloma for starters. You can have those proteins, those light chains, can clog up the kidneys. High calcium levels can damage the kidneys as well. If you have other medical issues, let's talk about keeping those under control. Diabetes, hypertension, if you get dehydrated, all those things can impact your kidney function. And sometimes it can impact your kidney function irreversibly. So in terms of medications, we worry about certain antibiotics. We tell patients if they're getting CT scans to avoid contrast. Patients with diabetes, metformin can be toxic to the kidneys. We worry about patients taking NSAIDs such as ibuprofen and or Aleve and things like that. So use those very cautiously. So again, protect those kidneys as much as possible. For prevention, drink. Plenty of fluids. It doesn't have to be water. It can be anything. Pretty much anything you drink is 99.99% water. But again, stay hydrated. That's really going to be the big part right there. So treatment, well, initially treat the myeloma. If we treat the myeloma, then we can certainly help protect your kidneys. Some patients will start out on dialysis. And with some patients who are on dialysis at the start of their myeloma treatment, their kidney function can recover and they can actually get off of dialysis. Some patients aren't quite that fortunate and they may remain on dialysis for a long time. But protecting the kidneys is going to be a lifelong issue with patients with multiple myeloma. Along with that, bone damage is a big thing. Now, we know that 85% of patients are going to experience some type of bone disease during the course of their disease. Now, not all of that's going to be symptomatic, but for many patients, it will be. So bone health is a really, really important part. So we think of nutrition, we think of exercise, those weight-bearing activities. We think of keeping your vitamin D level up. We check vitamin D on every new patient who's diagnosed with multiple myeloma, making sure that level is up. Again, vitamin D is made in the skin and upon exposure to sun. And a lot of us don't get that kind of exposure these days for a wide variety of reasons. For those patients who are on the bone strengthening agents, very often your calcium can be low. So if approved by your provider, taking calcium vitamin D combination is important. And then we have the bone strengthening agents. Zometa or zoledronic acid is one. Pamidronate we used in the older days. And then the newest one on the market for a couple of years is denosumab. And that's really good for patients who have kidney dysfunction. The Zometa and the pamidronate can be toxic to the kidneys. So patients who already have kidney dysfunction, it's difficult to use that. The denosumab, however, is really good. So from that standpoint, and again, any new pain issues that you might have that do not go away, those should be reported to your provider. Here's the other big bad one, I think, behind steroids. This could be the other big bugaboo for patients. And that's peripheral neuropathy. And if you go back to those slides again of all side effects of those medications, we have a number of our medications which can cause peripheral neuropathy. And it's much like when we talked about DVTs, what's our primary? Our primary prevention. Prevent the neuropathy from happening. And then secondly, if you do get the neuropathy, report the symptoms to us. And I'll kind of explain why. But the symptoms, what are the symptoms? They're shown up here on the left. And I've heard everything from numbness, prickling, tingling, pain, walking on sand, just electricity, everything under the sun, which we'll be talking about peripheral neuropathy. And the thing about peripheral neuropathy is it can be reversed, at least early on. So if a patient starts to experience peripheral neuropathy, we can actually do some modifications which may help reduce that neuropathy or actually make it resolve. So how do we do that? Well, sometimes we can just reduce the dose. So if we have bortezomib, which is well known to cause peripheral neuropathy, at the highest dose, we can make a dose reduction then as well. And you should not worry about dose reductions, because if the peripheral neuropathy gets worse to the point where we can no longer use the drug, that's not effective at all if it sits in the pharmacy. However, a dose reduction of that drug works perfectly fine in patients if we continue to give that to you for a very long time, as long as it's working. What we really don't like to do is discontinue a drug that's effective and working, and we have to discontinue it due to a side effect that we have not managed. So we can do some dosing changes as well. Certainly keeping the skin moist, that's one thing which helps. So cocoa butter there. There are some supplements that people use, sometimes with success. I would caution the B6, because excess B6 can actually cause neuropathy on its own. Some people take some over-the-counter type of medications or things they found on the web. Those are perfectly fine, but we typically will tell patients don't take them on the day that you take your therapy, because a lot of those we don't know how they interact. And we always talk about a safe environment. And if worse comes to worse, again, if peripheral neuropathy gets bad, again, we can change your treatment, modify your treatment. But again, we do not want to, again, negate any treatment due to a side effect when it's working. And some patients, I will say, honestly, get great success out of acupuncture. It's typically not paid for by insurance, but it's a good option for at least to try if you have the possibility of doing so. And then the last slide here is, I think, a big one for patients as well, is that pain prevention, pain management. Again, if we can prevent it, that's fine. Very often patients present with pain because they have lytic lesions, which are causing the pain, those bone lytic lesions, which are very common at diagnosis. So again, bone disease, the neuropathy, if it gets bad, can cause pain then as well. And so how do we manage it? Well, you prevent it whenever you can, quite obviously. And again, we don't want the neuropathy to get so bad that it causes pain. We always use bone strengtheners, again, those bisphosphonates as well. We do everything we can. We can do other interventions. We certainly have pain medications that we can use, and the type of pain medication we use actually depends upon the source of the pain. Bone pain is very different and treated differently than peripheral neuropathy is, or pain is secondary to peripheral neuropathy. And again, that complementary integrative stuff is really good. And if you have a supportive care clinic, they're great at managing some of these things then as well. And so I think I believe that's the last slide here, and that's it. Questions? Kelly, I'll take it back to you to moderate.
All right. Well, thank you, Kevin. I really like that slide deck at the end of this presentation, or the presentations. It really puts a nice hand around the whole project and another aspect. Well, folks, listen, I want to get your feedback. You can, if you look at that bar that's under your, down at your lower part of your computer, you'll see a clipboard. So please commit this, please here, complete start again. Click here to complete the feedback survey. I was going to say something else, a foundation or something, but you can get this information, of course, on myeloma.org. And I'd like to go into the final Q&A here. Doctors and Kevin, I see about 45 questions. Let's say for number 45, who would like to take that one? Ola, you want to take that one, number 45?
Yeah, let me just read it. What's the latest research? Well, there's no, so for osteopenia, osteoporosis, and smoldering myeloma patients, we don't have that much about knowing about reclast and smoldering myeloma and definition about that, in osteoporosis, I mean, I don't have, of course, osteoporosis, you have to treat that osteoporosis patient, regardless if they're smoldering or not smoldering. But if the patient doesn't have the osteoporosis, I don't see any kind of utilization of using any of the bisphosphonate for these patients. So we have to kind of go with, with kind of evidence. I don't know if Dr. Ganguly, do you have any information about using any bisphosphonate or Xgeva in smoldering myeloma without any, any utilization in these patients?
Honestly, I do not. Other than if the patient has a diagnosed osteoporosis with the smoldering myeloma, just because of the diagnosis of the smoldering myeloma, I have not read any research on using either bisphosphonates or Xgeva as a preventative measure. I have not.
I know there have been some studies about that, but I didn't see any randomized trial to make us a little bit impressive about that, to be honest with you.
Now, there's a question number 41. Is shingles prevention necessary after receiving the Shingrix vaccination?
That's a very, very good question. The reason I want to answer that question is because I just had a patient this Friday calling in with shingles after having had Shingrix vaccination and had been on acyclovir prevention post-transplantation. So the answer is, remember, the vaccine trials were all on healthy volunteers. The vaccines have not been tested on patients, especially with myeloma and transplant. So we really do not know the extent of vaccine protectiveness in patients with myeloma. So in general, after the 2 rounds of Shingrix shot, the incidence of future shingles goes down, but it does not go down to 0. And I have had several patients coming out with shingles even after the Shingrix vaccination. So there is always a distinct possibility. If somebody has completed the Shingrix shots, I would say pay attention to any new blister or any new pain that is shooting or tingling in either the trunk or in the limbs, and contact your doctor immediately, because it could be a pre-shingles and shingles might be coming in a day or 2. So if you are not on acyclovir and completed the Shingrix vaccination, still there's a minority of patients who can still have shingles.
And that's no fun, is it?
That is no fun.
Let's see. Number 40, do you see decreased urine output on the day of RVD injection, and how do you manage fluids? Number 40.
Kevin, would you like to take that?
Yeah, I will. I don't know that we see decreased urine output on those days at all. I'm not sure exactly what you're specifically referring to. So I think on those days, I would keep your fluid intake just as much as you would on any other day. Revlimid is cleared by the kidneys. Velcade is not. And so I have not noticed that. Have either of you, to Dr. Abdallah or Dr. Ganguly, seen anything?
No, not really. I think, Kevin, you are right. But on the other hand, if somebody gets skyprolis, then we definitely give fluid. In the first round, we sometimes give IV, but later rounds, we tell them just give hydration by mouth before coming to the clinic.
Right.
Question number 39. Has anyone had any success in alleviating and or dealing with kyphosis caused by compression fractures?
Kevin, you want to talk about vertebroplasty?
Yeah, and I think that's something that has to be done pretty early. So kyphosis is that kind of, I would describe it as kind of a hunching forward that you're going to get due to these compression fractures. And so the compression fractures can be alleviated at least early on if we can actually go in there and they can inject a plastic into there and actually increase or reestablish the size of those vertebrae, and so that can happen. Unfortunately, if you've had the compression fractures for a long time, that doesn't work so well. So very early on, it's very successful and very successful at taking care of pain as well, but not so much after these compression fractures have healed or been around for a long time.
Thank you, Kevin. We do have a question about the COVID vaccine. Is it safe for myeloma patients to take the COVID vaccine?
The answer is
either one.
Yes.
So the answer is yes, it is safe. Like anybody else, COVID vaccination can give, some headache, some fever, transient body aches, rarely anything serious. The incidence is probably 2 to 3%. But I would strongly recommend getting the COVID vaccine. The only thing that we do not know, because again, the same thing, the vaccines have been tried in healthy volunteers. We have not tried that on our patients. So actually, we are running a trial where we are checking the antibody before and after vaccine. So if someone is in a Kansas City area and wants to know whether the vaccine is effective or not, I would strongly recommend contact our KU Cancer Center and ask for Canine, C-A-N-I-N-E trial, which is trying to answer that question, whether the COVID vaccination is effective and how effective it is for our cancer patients.
All right, let's go to question 30. Could you comment on the challenges in treating post-BCMA treatment relapse?
Dr. Abdallah?
Of course, there's going to be a lot of challenges because we have less, studies about that. Now we're starting developing these studies. The challenges is going to be about, do we utilize other options? We go and review other treatments the patient got. Are these patients really triple refractory and penta refractory? So, and also what type of BCMA these patients got? Some of these patients maybe got, again, CAR T-cell just got approved last month, and not everybody got maybe the higher dose of the CAR T-cell. And some patients maybe got belantamab in the past, and I have some patients who actually stopped the ADC BCMA because of eye toxicity, or they decide they don't want to do it. So we have to kind of be very careful when we define these patients. It's kind of a new group of patients like the triple and penta refractory. The strategies is always depend, do you utilize alkylating agents? Do you use one of the 3 drugs that the FDA approved, like including melflufen, base therapy, or selinexor? It's going to be really a challenging question because these drugs were not actually treated. They were not used, or they were not actually utilized in the clinical trials after BCMA treatment. Now we're seeing some studies that they're actually specifying post-BCMA drugs. And these studies are going to actually answer us much better questions. Some of the bites actually they're talking about, that some newer targeted therapy, I think. In our institute, which I think that's what we do, we always take these patients to a clinical trial. We always have to utilize a clinical trial for that. But out of the clinical trial, we review all these treatments that these patients got, and we see exactly if we can reutilize these drugs or use newer treatments that the FDA approve. But we don't know, or we can't give them an accurate answer due to the fact that we have lack of clinical trials for this specific group of patients.
Yeah, Dr. Abdallah, I'm going to absolutely echo what you just said. I would be extremely interested in knowing what BITE does after BCMA CAR T. So we'll see how that pans out.
Well, here's question 38. My mom has increasing pain around her neck, or around her back, and ribs leading up to being diagnosed. Will this subside when the myeloma numbers go down?
This basically goes to the same question that Kevin had already answered. We need to find out why there is pain. Is there any plasmacytoma? Is there any vertebral collapse, fracture that is pinching the nerves? And if that is so, then definitely we need to talk about early kyphoplasty, which is the cement injection in the collapsed vertebra. So that will definitely help the pain. And then, yes, the answer is once we start treatment, many of our patients from the potent anti-myeloma drugs, even dexamethasone has significant bone analgesic property. So the pain definitely we expect to improve as we treat myeloma, plus minus with or without kyphoplasty. So I would recommend finding if there is any place that we need to attend to by kyphoplasty and continue the myeloma treatment. And I think things will definitely get better. Will it be completely going away? Time will tell, but definitely it will get better.
Okay, let's go for the final question, number 52. The newly FDA-approved myeloma drugs, ABECMA, And
Idocel.
Go ahead and answer that question.
So they're talking about Idocel and melflufen, if I'm not mistaken. Is the Bibextro is the melflufen? I think that's right. So yes, these drugs these treatments got approved, by the FDA, and do it apply to all myeloma patients? We have to be very specific about who are the patients that we really want to focus so that we can give the right treatment. And I think our clinical trials are very specific in heavily pretreated patients. These two types, triple refractory myeloma or pentarefractory, they can get the Idocel or Abicma. And I talked to Dr. Ganguly about that. We want to really actually make sure that it's safe treatment. It has some side effects. We just don't want, because our goal eventually is to benefit from these drugs for these patients. So not all myeloma patients may be able to take, for example, the Abicma, the CAR T cell. So let's say a patient have very important saying like performance status is 4, like he's on a wheelchair, not due to myeloma, due to other things, or he have unfortunately end-stage renal disease on dialysis. We might be very concerned about making things worse, so we don't have enough studies. But there are some issues we might actually argue with it. Like let's say a patient who have congestive heart failure, but it's stable and it's not decompensated, and the patient is doing fine, and we evaluate the some classification, New York heart classification, that's one, and the cardiologist says the patient is stable. We might consider this patient is exempt and we can take him to do it. A mild renal failure might be also very great to take these patients. So we have to really evaluate the main exclusion, because also these are clinical trials. They didn't include a lot of patients. So we might look at these, again, we're not going to be very strict like the clinical trial, but also we don't want to kind of anybody who comes to the room and with a bad performance status, with a lot of high comorbidities, give them CAR T cell and causes harm for these patients. And the same thing apply to the melflufen drug as well. So we have to be very careful for all these patients. But where do we utilize it from all the treatments? After multiple lines of therapy, and we agreed 4 lines of therapy. That's our agreement, that after patients fail 4 lines of therapy that include the CD38, which is either the daratumumab or isatuximab, Revlimid or pomalidomide, and also proteasome inhibitor, whether it's Velcade, Ninlaro, or carfilzomib. So when you see this type of patients, this patient meets the criteria for the disease term for getting the Idocel. The other things is that to see if the patient is fit enough for getting the CAR T cell.
So one thing we must clarify, when the FDA approved indication says after 4 lines of therapy, sometimes it causes little confusion in people's mind. What do we mean by lines of therapy? I had received RVD, then I had transplant, then I have received LEN maintenance, then I had received Cyborg-D. So I've already crossed 4 different kinds of treatment. Not really. Lines of therapy means as long as the patient is on a particular path and the myeloma has not relapsed, that's considered as 1 line of therapy. So for example, somebody comes with myeloma and we start them on RVD, taken them straight from the RVD to transplant and then put them on LEN maintenance. That is 1 line of therapy. And then on LEN maintenance, if somebody relapses and then we change the LEN to say Kyprolis Revlimid Dex, well, that's the 2nd line of therapy. But if the patient gets a second transplant as a part of the KRD followed by transplant, then K maintenance, well, that is just another 2nd line therapy. So the lines of therapy and the number of the chemotherapies or therapies, they're different. So 4 lines of therapy has to be given before we can give the Abicma. So just be careful about the terminology of lines of therapy.
Good point. Very good point. Well, does anyone else have any last comments they'd like to add to our program today, which was incredible?
Well, I want to take this question number 43 because that's an interesting question. If that's all right with you, what is the impact of factor V Leiden on transplant or therapy? Well, factor V Leiden is a mutation that imparts hypercoagulability in somebody's vascular system. But if the factor V Leiden, you are just a carrier, that does not impart high risk. But if somebody has already had a clot, that definitely imparts high risk. So one has to be careful with a patient with factor V Leiden and past history of clot, giving treatment that can cause clots like Revlimid. We have to give a strong, what we call is a thromboprophylaxis, like prevention of deep vein thrombosis. So factor V Leiden and history of clot does pose a challenge when we use medicines that can cause thrombosis in patients with multiple myeloma. So my recommendation is, if somebody does have factor V Leiden mutation with or without clot, be very clear to your treating oncologist and say that this is a condition that I have, and the oncologist will decide the proper treatment for that particular patient. So this is a very good question, and it has got strong implications in the therapy.
And, it goes to say that it's very important for the patient to get the right doctor, the right opinions, and so forth in here, because the treatments are very, very complex today. And that's why a lot of them are so successful. Dr. Odula or Kevin, would you like to say anything?
One of the major comments I would like to add, we have really great options of therapy. We have a lot of clinical trials. We would like to always utilize these clinical trials for our patients, whether it's smoldering myeloma, maintenance, and all these stuff. So, kind of visit our website, try to contact our clinical trial department. We also have our CAR T-cell clinical trials and also commercial availability. So, try to also contact us, to evaluate. Don't come in the last minute. Unfortunately, the patients have been sent to us after they become on dialysis, and it's very difficult to put these patients on either a clinical trial or the commercial CAR T-cell. So we really like to see these patients before they deteriorate very fast, after they're triple refractory, at least, or putting them on our data, on our list of patients to keep our eyes and watch them very closely. We've been successful in that since the CAR T-cell got commercially available here in KU, to get these patients and enroll them in the clinical trial or get them into the commercial CAR T-cell. So we would like to do it also for other patients as well.
Fantastic. Kevin, would you like to add anything to your presentation?
Yeah, I'd like to say that utilize your oncology nurses. They've been doing this for a good long time, and they have a lot of great information. So do not be afraid to bring up side effects to them, and anything they can't answer, I'm sure they will take to the providers. The next thing I would like to say is, Kelly, happy birthday.
Oh, thank you.
Yeah, and you know what, Kelly? I won't tell you this, but it's my birthday today as well. So
is it really?
Oh, wow.
It really is, yeah.
Well, you're much younger than I am, so it's okay.
Yeah, I don't know about that. So, but anyway, happy birthday.
Yeah, it's going to be a good one. The dinner and cake, so I can't complain about that. Well, gentlemen, I know it's a Saturday. I know you're busy. I know you're trying to take a break from work. I can't tell you personally how much I appreciate you taking the time to work with the International Myeloma Foundation and myself. I'm sure there's a lot of hand claps out there for your presentation. Thank you again, and we're going to go through the final credits here. Have a great day, guys.